My name is Hina Javed Shahid. I am the chair of the Muslim Doctors Association and a GP with a background in public health. The disproportionate impact of COVID-19 on Muslims has been clear from the outset, and the lack of adequate government response even more visible. Muslims have the highest risk of dying from COVID-19, as shown in a government report. This is not surprising and represents the embodiment of long-standing structural inequities known to increase vulnerability, exposure, transmission, and adverse outcomes from COVID-19. Additionally, barriers to accessible public health messaging, healthcare and PPE at work, and constrained opportunities for social distancing and self-isolation due to living conditions lead to reduced protection. 50% of Muslim households live in poverty, and they are more likely to face barriers in employment, education, income, and housing. During the pandemic, Muslims have worked in high-risk jobs as key workers and in public-facing roles, keeping the country running, but paying the ultimate price. Government policies such as austerity and immigration worsen racialised health inequities and create barriers to accessing healthcare. Security policies predating COVID-19 have created suspicion around testing and surveillance in the community. Muslim patients already face barriers in accessing healthcare and report discrimination and reduced satisfaction and quality of care that they receive from healthcare providers. These contribute to delayed presentation with more advanced disease and deaths. The inconsistent and unclear messaging lacking linguistic, cultural and faith sensitivity has encouraged the circulation of harmful fake news and a preference for alternative sources of information. The lack of capacity in the testing infrastructure, increased digitalisation of health services and fears of surveillance risk further exclusion. Divisive media and political narratives that blame and scapegoat Muslims for transmission, despite evidence to the contrary, have been accompanied by an increase in Islamophobia and heightened fear, mistrust and stigma. Social cohesion and compassion are vital public health assets, and increased media accountability is necessary and urgent. On the front line, Muslim healthcare workers have reported discrimination, bullying and harassment, and unfair deployment to high-risk areas. They have struggled with accessing timely testing and culturally relevant PPE and risk assessments. Whilst politicians and the public have thanked them with claps, healthcare workers have reported stress and burnout affecting their personal and professional lives. Colleagues have sacrificed their lives as high exposure and inadequate protection led to avoidable frontline worker deaths. These deaths need thorough review, and frontline workers must be given the robust health, safety and income support that they deserve. The consistent lack of transparent and accountable policy making has cost lives, and Muslims, ethnic minorities and other protected and vulnerable groups have borne most of the brunt of systematic government failings. Data on all legally protected characteristics, which includes religion, need to be collected and published for all health outcomes and interventions to protect the most vulnerable. Communication and trust are key. The government needs to engage with grassroots organisations and consult early to co-produce localised and contextualised messaging and interventions that are timely, relevant, accessible and applicable, inspiring trust, confidence and engagement. It is time for the government to act responsibly and make a firm commitment to eliminating structural inequities, racism and Islamophobia and the policies that entrench these. This must not be relegated to long-term goals. With very real fears of an impending second wave, it is vital that lessons are learned and community insights are actioned urgently to prevent further devastation and disparities.